Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Today is Wednesday, December 2nd. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Maryland Community of Practice for Supporting Families webinar series. This is webinar number 13, DDA's Participant and Family Survey on COVID-19, the results. This session is being facilitated by Mary Anne Kane-Breschi, Director of Family Supports for DDA, and also with us today is Ian Collins and Drew Smith, DDA consultants. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There are two options for listening to the webinar, by computer and by phone. There's a handout for the webinar, and you can find that in the handout section in the panel to the right of your screen. They can also be emailed if you are listening by phone. We are recording the webinar, and that will be posted on the website. And if we have time at the end, we'll take questions directly related to the webinar. And if you have a question regarding services and supports, please contact your local regional office. If you have questions related to Appendix K, please submit those to dda.toolkitinfo@maryland.gov. In addition, we're interested in highlighting how people with disabilities and their families are supporting and caring for one another during this pandemic throughout the webinar series. If you're interested in sharing your story, please contact Mary Anne Kane-Breschi directly at mary.kane-breschi@maryland.gov or me, donna.will@maryland.gov. So now I'd like to introduce Mary Anne Kane-Breschi. Good afternoon.
Good afternoon. Thank you, Donna. Good afternoon to everyone. On behalf of the Maryland Community of Practice for Supporting Families, welcome to our webinar. The purpose of this series is to bring people with intellectual and developmental disabilities, their families, however defined, along with others, together in order to share information and ideas and learn from one another in an effort to support each other to build our knowledge, skill, and resiliency within ourselves and the community as we find our way through COVID-19 and beyond. Throughout this series, we have discussed and continue to discuss and address a variety of topics and concerns with which individuals and families are facing related to COVID-19 in everyday life. We do this with the help of invited guests and subject matter experts, and of course, through the lens of charting the life course framework. For those of you who are unfamiliar with Charting the Life Course, it is a set of universal principles and tools. Its fundamental principle states that all people have the right to live, love, work, play, and learn, and pursue their aspirations in the community. It was developed by the University of Missouri, Kansas City Institute for Human Development Family to Family program to help people with IDD and families create a vision for a good life. Think about what they need to know and do, navigate and develop resources if need be, and finally, overall, just to discover what it's going to take to live the lives of their choosing and to do it. These principles inform the work of the Maryland Community Practice for Supporting Families, as well as that of the Developmental Disability Administration, as we work to create regulations, policies, and practices to better support people with IDD and their families across the lifespan. In every webinar, we highlight one of the principles of Charting the Life Course, and it's the one that pertains to the topic we're discussing. Today, our focus is on transformational policy and systems change. Simply put, this principle states that true transformation happens when systems engage people with IDD and their families in policymaking. After all, people and families are the recipients of services. Engaging them provides them with the opportunity to influence planning, policy, implementation, research, and the revision of practices that affect them, thus enabling systems to better support them across the lifespan. It also requires that programs, organizations, systems, and policymakers consider in their policymaking the person within the context of family and community. The DDA's Participant and Family COVID Survey is a perfect example of this engagement. DDA wanted to hear from people and families about their experience with COVID, its impact on their lives, services that they are or aren't receiving, or services that are different, and also what is going to be needed going forward. So with that, I'd like to introduce our guest, Drew Smith, a DDA consultant. Drew will provide us with an overview of the findings of both the provider COVID-19 impact survey, as well as the individual and family survey on COVID-19. Drew, welcome, and thank you for being with us today. And with that, I'm going to let you take it away. I will move the slides forward as you asked me to.
Great. Mary Anne, thank you so much, and thank you for the invite today. I just want to say I am a staunch supporter of charting the life course. I think that what Maryland has done to really ingrain it in policy and decision-making is really notable, and really a commitment to the lives and the choice and the quality that DDA services can really provide. So I'm very grateful to be here today, to be meeting with all of you, and thank you. To start out, so like Mary Anne said, we're going to talk a lot about data today, but hopefully really also about the implications of data, given the uncertain times we've all been living in since March, a little bit before even, as we look at cases, and understanding how it shifts DD systems, and specifically how it shifts DD services within Maryland, and what we've learned from it, what we can do with it, and what comes next. So as we think about the topics of today, I know it's hard to go into a data presentation thinking, oh gosh, at what point will this end? So I think it's important to set some structure here. So what I hope to do by the time we get through this is introduce both the surveys that we as consultants at DDA partnered with DDA on to go out and seek some of this information. What was the intent? What were we really trying to gain from that information? And what was the goal of the surveys? Then we're going to take a look at the system background. So, part of what we tried to do in the survey was say, well, what's happened to people and providers through this process? And where are people, as we were asking these questions, in how they're interacting with services? We'll then move into, this idea of virtual supports and the impact that it has had on services. And so, one of the greatest things I think we've seen come out of this is new ways to deliver services. But anytime we introduce a new service delivery model, we need to understand what the impact has been, and not just assume that it's the right service delivery model for everybody. So we'll take a look at data here to see how providers have set infrastructure to provide services virtually or through remote structures, and how families and individuals have interacted with that information. And then really move into, what does this all mean? What do we do with this information? How do we move forward as we're still continuing through this COVID-19 pandemic? So Mary Anne, if we can go to the next slide. So we conducted, in partnership with DDA, 2 surveys. And I think, as Mary Anne opened up and talked about, this idea of systems transformation, the reason we conducted 2 surveys is I think it's important for us to understand providers, right? I mean, they are the supply side of the service structure, and they're got the capacity, they've got the infrastructure to supply services, but then also the impact of those services and the impact of the pandemic on families and individuals, from an economics perspective, the supply or the demand side of services, right? So what we wanted to see is, from providers, what is the impact on provider operations and really the stability within providers been like over COVID? So to do that, we look at things like, fiscal stability, program closures. Really, however, when we think about the context of providers, we wanted to look at what has been the impact on the direct support workforce. So as everyone on this phone knows, we went into a pandemic with a challenged workforce, right? It's always been hard for us to get adequate and quality workers into the service system. A pandemic does not help that. And so what we wanted to know was, what was the impact of this on provider agencies, because that will determine what providers look like as services come back online. On the family and individual survey, what we really wanted to know was, how are families doing as they're trying to refigure out this survey, as programs have closed, as services have shifted from both the, getting by on a day-to-day basis to health status, and then really, and I think importantly, what have families and individuals learned through this process, and where do they want to see services move as the pandemic at some point, knock on wood, starts to roll away. And so, yeah, I think from a goals perspective, we really wanted to use data and to, I think DDA should get some credit here. Patricia, Bernie, Valerie, and the team has really said, we don't want to do this based off of just stories. Stories are important here, but we also want to make data-informed decisions on what programs look like. If we're going to come out of this in a different system, we need to do it as informed as possible. And so they really, and I will say that Maryland, from my experience, is the furthest along in using data in this process, and is really one of the only states to go and actively seek this information the way that Maryland has said, what can we learn from this process that will A, help us make sure that people are safe as it continues, but B, as we think about what the DDA service system looks like moving forward, we're building a system that meets the expectations of families and individuals, and we have support structures that are appropriate and adequate and important. So let's go ahead and go to the next slide. So one of the questions anytime we look at data is, how many responses are we talking about, right? If our sample is too small, then it becomes challenging to make decisions. And so one of the goals of both of these surveys was to really work with as many stakeholders as possible to get these surveys out. We wanted as many responses as we could possibly get to get the biggest picture of the service system that we could. So what we see on this slide are two tables. The table on the left is the response rate for the provider survey. The table on the right is the individual and family response. So let's start on the first table on the left. So the provider response, what we wanted to make sure we were capturing was a good sample across all the program structures within DDA currently. So what we see is across the board, we got responses from between 32 and 37% of agencies providing all of the services within DDA. That's really good. That gives us a strong structure, a third of the entire provider network, to better understand what the impact has been. The column to the right shows us how many individuals who receive services through DDA funding are represented by those agencies. So again, we're seeing that across the board, we're getting close to that 50% of everybody who's accessing services by those agencies. So that tells us that we hit a diverse group of agencies. We also hit some of the bigger agencies that were supporting more people. What I can also tell you is we also got responses from smaller agencies. So we have a really good sample size in here from the provider side. On the right-hand side, we see the individual and family survey responses. And for those of you on the phone and the intent of this survey, I really want to applaud you. I mean, 1,300 responses to a survey like this is significant. We've seen other national organizations trying to do surveys similar to this that have not had response rates like this. And so what it does, so when we see 1,392 responses, that just increases, not to become a stats class here, but the statistical significance of responses, of what these responses mean. And so as we look at the data, it makes us feel more confident in being able to identify, some of the trends that we're seeing or some of the things that we might be able to learn from it. So we broke this out and show that we got a good sample, primarily around the traditional services. We do definitely have representation in here around self-direction, which was really important, especially as we're managing through COVID. I think self-direction is an important voice for us to just keep track of and understand the impact when you don't have the same structures as a traditional service model. But you'll see we got good responses from both individuals and from families around their perspective of the service structure. So, I think this slide, again, if you're a data person, is important just because it shows us that we have strong representation of DDA service structures to be able to look at this data now that we'll jump into and be able to say, yeah, we feel confident that what we're looking at is a realistic picture of what's really happening. So let's go ahead and go to the next slide.
Hold on a second. Hold on one second, having a little technical difficulty here in advancing my slides. not allowing me to. Sorry about that. There we go. Okay.
All right, perfect. So we're going to start on the systems background. So again, what we wanted to look at from a systems-wide perspective was what has been really from the provider side, what's happened within staffing, what's happened within those DSP networks, and what has been the impact of COVID. So we know that turnover within DSPs has been consistently high across all DV programs nationally, not unique to Maryland, but in Maryland. And then from the family's perspective, where are families sitting right now as far as self-identified health risks, as well as interest in continuing congregate services as we move forward. So on the slide here with the pie chart, there's a lot going on. So let me kind of break this down. So what we wanted to look at across a 3-month period, so from March 1st to May 31st. So we wanted to say from pre-pandemic, so before the pandemic started, March 1, through operating in the pandemic for the first couple of months through May 31, how have DSPs moved within the system? So in the pie chart itself, we see 3 primary pie pieces that we'll talk about. So the big blue piece says existing staff. So this is good, right? So we see that across that time span from March to the end of May, that staff stayed relatively consistent. So from March 1st through May 1st, really the majority of staff stayed where they were. They stayed in the provider agencies, and they didn't leave, they didn't move. What we see in the orange to the top right is new hires. So that we actually see that during this period, agencies were bringing on new staff. So that's great, right? We want that 78% plus that 7%. That tells us what our total market of DSPs is in providing services. Where it gets a little bit more complex, and really the intent of what we wanted to learn from this survey is that brown pie piece and then the bars to the right of that. So really we wanted to understand how many DSPs have left the service structure during this period, because that's going to have significant impacts across many aspects of the DVA service system, from the capacity to provide service to the quality of service, to what types of services can be provided as we continue through the pandemic, and then ultimately the need for or not remote supports. So what we see during this time is 15% of all DSPs left in this 3-month period. So it's about just shy of 1,100 DSPs. So what we also wanted to know is we know that sometimes DSPs leave for a whole lot of different reasons, right? Sometimes a DSP says, look, I took this job just while I was in college, I graduated, I'm moving on. Or we wanted to know what of these reasons were specific to COVID. So what we found is in that top gray bar, about 27% of DSPs, they didn't really give a reason, right? So they may have left for COVID or not COVID. So we have to keep that in mind as we think about some of these numbers. We just don't know why those 300 DSPs left the service system. Underneath that, the yellow, we see about 20% of DSPs left for non-COVID reasons, right? They just didn't want to be a DSP anymore. It wasn't the right job for them. They took it understanding that it wasn't a career path for them. That's what we would call kind of that natural progression of DSPs. Everything below that are what we would call COVID-related reasons. So there are 3 COVID-related reasons that we looked at in the survey. So first, that light blue, 12% of DSPs were COVID-19 related voluntary separations. So that means that the staff person decided, you know what, I don't want to be a DSP during COVID because A, I don't have childcare, or I can't get transportation, or I don't feel safe providing services as a DSP. So I'm going to leave because I don't want to continue because of COVID. So they're choosing to leave on their own, and it is COVID related. Let's drop down to the next blue bar, because I think this is the more important one here. So what we also found was 34% of those separations were COVID-19 employer terminations. So what that means is programs are shutting down, and so providers are unfortunately letting DSPs go. They're saying, I can't operate my day program. So I'm unfortunately am taking DSPs out of the marketplace because of COVID. So in total, we saw about 500 separations related to COVID of DSPs. What that means is of all separations, that's about 64% of total separations for where we know a cause of the separation. So taking out that 27% we talked about earlier, were COVID related. That's significant data to me. We also looked at this, and many of you might be familiar with NCI and the staff stability survey, to say, well, how does this relate to separation rates that we typically see within Maryland? And so we looked at it for a quarter of time in NCI data versus our quarter of this COVID-related period. And what we found is during this 3-month period, staff separations were about 104% higher than they are in a standard time. That's important. It's important for, I think, everybody on this phone, because you think about your sons, your daughters, yourself, and the support structures that you need to be able to achieve your outcomes, and understanding that we now have fewer DSPs than we did coming into this in the workforce. And what we know about DSPs is once they leave, it's really hard to get them back. And so again, to the credit of DDA, this was really driven by, thinking about providers and reopening and their revenues is important, but what we need to make sure is that we have an infrastructure for reopening. So this data, and this is data that I think only Maryland has access to at this point, no other state has thought about it this way, to me is the most critical, because DSPs are that linchpin of the service structure. Without DSPs, we don't have services. And so what do we do with this? So let's go to the next slide, Mary Anne. So the next question we needed to ask, right, is where were these separations? Because as we think about it, again, from a systems perspective, were separations happening for these DSPs across the board, or were they program specific primarily? And so what we saw was across the 3-month period, and if we look at the second to the bottom line there that says facility-based licensed meaningful day services, right out the gate in March, the vast majority of separations happened there. Not too surprising, right? We know that day programs started shutting down as soon as the pandemic hit, to get people out of those congregate settings, and really people went back into residential placements. So that data, while important, was not super surprising. What we saw, though, throughout the 3-month period is the continuation of day services were impacted by staff separation. So the second to the top, we see community-based meaningful day and employment services. So what we saw was after that initial impact on the facility-based services, community-based meaningful day services had sustained impacts with staffing for April and May. So, as we look at this from a systems perspective, we know that day services, both facility-based and community-based, have a very different look to them now from a staffing perspective than they did coming into this. And so again, as we just think about this, what does this mean for reopening, but what does this also then mean for DDA moving forward? This, I think, is important data as we think about infrastructure and we think about capacity. Let's go to the next slide. So we've talked a lot about providers. And again, I think it's important to talk about providers in the sense of we need an infrastructure for people to be supported. But it's also really important to think about this from a systems perspective of where are individuals and where are families right now in thinking about what reopening may look like, or thinking about what prolonged COVID-19 pandemic world looks like. And so we see two pieces of data here. The one on the left looks at self-identified risk to severe illness from COVID. So we ask, do you or a family member think that you are at high risk of severe illness from COVID? Because as we think about this, when we think about the impact that this has on reopening and congregate services, or just people getting more engaged back into community life, something that we're all dealing with right now, it's important to understand where everybody's sitting. And so what we found through this is that about 42% of individuals have identified as being at risk of severe illness through COVID. What we also found was about 54% of family caregivers have also self-identified as being at high risk of severe illness. And so if we think about the data around the role of aging caregivers in supporting individuals with disabilities, I think this number is probably actually low, right? I think that this might be higher, and it's a significant concern. If we reopen services, or if we start to become more engaged in the community, but then we have our primary support structure is within our home, within our family, what is the risk of them bringing that back in and then taking somebody out of being able to be supported by mom or dad or brother or sister, and then having to come back into that traditional service system? So, I think what this shows us is families are still struggling with this, and for a whole lot of reasons, right? We've got comorbidities and also aging caregivers who have their own comorbidities, but it tells us that there is still significant concern within the DDA IDD population of services reopening, or of people starting to re-engage in what we would call traditional community life. Next, we asked, so one of the biggest challenges that we all have right now is who wants to wear a mask? But it's important, and we know that that's an important part of preventative care. And so we asked, are you capable of participating in preventative care to help to reduce or eliminate the spread of COVID for yourself? And what we found is there are a lot of family members and self-advocates who have identified that they're not capable without significant supports or without some type of support of taking those preventative measures. So again, as we think about reopening programs, or we think about going out and getting back into life and going to restaurants, if we know that people are still struggling with those preventative measures, then it's hard to do that and not understand that there's going to be significant risk of reopening programs. So again, I think what this shows us is there are people self-identifying as having challenges with the severity of potential illness through COVID, and there's still a struggle with people managing the prevention of spread within COVID. So I think, again, systemically, that's important context. Let's go to the next slide. Right? So then as we think about that, right, we think about that health data that we just looked at, we asked, if you received facility-based day programs, because as we think about this and we see the data from the CDC and we hear from the Deputy Secretary on his presentations on Fridays, really the biggest risk is around the facility-based services. And so we said, if you have received facility-based day programs, do you want to go back? And really what we have found is that 41% of respondents said that they don't want to go back. And so there are different reasons why somebody might not want to go back to a service, right? But two of the driving reasons that we found in our data was people don't want to go back because of COVID-19. I think that we've learned a lot through this process about the impact of pandemic and how it impacts people with intellectual and developmental disabilities, but how it also impacts people in any type of congregate setting, either in DD services or in any other sector, of how quickly it can spread and the danger of that. So I think it's been a real eye-opener about, do I want to go back into a structure like that? And what we saw is 36% of respondents said, no, I don't. What we also found is about 5% had identified that they don't want to go back because they've tried new activities or they've thought about new day activities that aren't facility-based. To me, this is the silver lining, right? So as we think about, what the DDA service system looks like and what it could be moving forward, this data becomes important. So people have said, I was doing this. I don't want to do that anymore. I want to try something different. So that could be employment services, that could be community-based day programs, but it shows us that people have been using this as a process to reflect on what they have been receiving and using it for thinking about what they want to receive moving forward. So I think there's a silver lining there about what do we do with this. Let's go ahead and go to the next slide, and we can actually go one more forward, Mary Anne. So we look at the system as a whole, and we see there are issues within the DSP workforce, there are challenges within individual homes around COVID-19, and there are ways people are thinking about services differently. On top of all of that, we also know that services during this time have been provided differently. So this idea of virtual supports has been something that we as a field of DD services have talked about for a long time, but have been relatively slow to act on. There are some states that have put their feet in the water and tried it, pre-pandemic. But what the pandemic has forced us to do as DD services is to say, can it work? And so what we've seen nationally, and I think, Maryland jumped on this boat very early on, is a movement away from in-person services into virtual supports. Now, of course, this has been mandated through the pandemic, but what it's provided us is an opportunity to try this idea in real time on a grander scale than what we've done in the past. So on this slide, we see two pieces. We see on the left-hand side, the percentage of providers who have said that, yes, they are doing supports virtually. And on the right-hand side, we see individuals and family responses of saying, yes, we are receiving services or have received services virtually. And so we see here that about 87% of provider agencies that responded to our survey said they're using technology to provide some type of remote support. On the right, we see that about 52% of families have said that, you know, they have received their services in some sort of remote way. Now, you should be asking yourself, why is it 87 and 52%? There's a mismatch. Yes. And so just because there's infrastructure for remote supports doesn't always mean that somebody has access to remote supports. Also, we can't guarantee that the providers who responded are the same providers providing services to the individuals and families who responded, right? So there's a little bit of a mismatch there. But I think generally what this shows us is there has been movement in the delivery of and the use of virtual supports. Let's go to the next slide. So it's important to, you know, yes, great, it's been used, but it's important to understand, do you like it and do you want to continue to use it? And so we asked the question of, if you're using virtual or remote services, specifically for day services, do you want to continue? Or do you want to go back to the way that things were? And what we see in this data is on the far left, we see that there's a significant group, about a third of self-advocates who responded, who said, I want to go back, right? I want to go back to day services the way that they were. I want to be around my friends. I'm done with COVID. Understandable, right? We've all had those moments. But it's important for us to keep that in mind, right? So we can't come out of this and say, well, we're not going to do any more in-person day services, because there's definitely people who interact in day services in person better and want to go back to that. What I find the most interesting in this data is the two bars right in the middle. And so it says, use virtual or remote services only. So this data surprised me as we started to analyze it and as we took a look at it. I thought that this would be lower, but as we started to dig a little bit deeper into some of this data, what we found is this 20% of self-advocates who said, I only want to do virtual supports, the majority of those respondents were ages 18 to 35. So to me, what that says is what we're starting to collect in this data is, yes, related to the pandemic and how people have been interacting with services, but also reflective of what younger people coming into services hope the service system will provide them. And so for a long time, I think we've heard from younger self-advocates saying, I'm connected to technology. Why is the service system not connected to technology? So through the pandemic, they've interacted with services through technology. And I think what this data shows us is that younger group is saying, I'm good with this. Like, I don't need to be at a facility-based day program. I can do this and feel connected and feel like I'm still having meaningful activities in my life through a virtual support structure. So I think that's interesting. I think what it just shows us also, just from a bigger picture, is as we move forward, it's important for DDA to be thinking about having both structures, right? So we can't mandate that we're only going to do one, because what data is showing us is that both are important. And so how do we build a service system now that has primarily only been one and now has the flexibilities to be both? So we can go to the next slide. So then we ask the same thing of providers, right? So we can't just say, look, everybody has decided that they want to continue virtual supports, and providers, you have no choice, or you just have to come along with it. So we ask providers, if you're providing services using virtual or remote supports, would you continue? And I think what we saw in our data is the vast majority of providers said, yeah, right? I mean, they would continue to do it. It seems to be working. People seem to be interacting with it relatively well. There are a subset of providers who said, it's not my thing. I'm not going to do this. About 11% of providers said, I'm just not interested. And that's important too, right? We have to think about that again from a funding perspective and from a service delivery perspective of how do we support providers to be able to operate then in that dual system as well. So, what do they need to be able to do services remote or in person, just like we need to be thoughtful of what do families and individuals need to be supported to access services virtually or in person. So let's go down to the next slide. So, as we think about technology, I think it's really exciting to talk about how it's worked or what people like about it, but we also really need to be thoughtful about what the barriers to technology are. And barriers to technology within IDD services or any health and human services are not new, right? There are cost implications to technology. There are limitations within Medicaid around technology. And there are just support changes around technology, right? Some people aren't as comfortable with using Zoom as others. Some people don't want to be sitting in front of a computer as much as others. And so, as we started to look at this and understand from the individual and family perspective around some of the barriers, and people in this data might have selected multiple barriers, which I think is also important. The number one area or barrier identified was they need more support to use technology. And it's not always available. Now, part of that is probably because providers are catching up to this, policy is catching up to this, but what it shows us is there needs to be more support structures in place if this is a model that moves forward. And there's also just people who don't know how to use it, right? And I think that's okay. And so as we think about this and we think about the communities of practice and we think about opportunities to help people become more familiar with technology, then using this data to help guide some of that and understand where people are in their comfort level or not being comfortable within technology gives guidance in how do we grow this new service delivery model should it continue. Let's go to the next slide, Mary Anne. So then, again, we look at both sides of the coin here. So from the provider perspective, there are barriers to providers, right? So we saw 13% of providers said that they're not currently using virtual support structures in their service delivery. So, there are different reasons for that. They have staff who aren't familiar with the technology or how to use it or how to support somebody. We've trained a DSP workforce all around in-person supports, and we don't have a training structure around supporting people virtually. It's very different when we think about supporting outcomes. We have to be mindful of the relationship and that connection that a DSP and somebody has and how that really helps support them overall. And we've not developed a training infrastructure to support DSPs to develop that skill set. We also see that agencies just haven't invested in it yet. And so, part of this is making sure that agencies have the infrastructure to support people. And we're not trying to, knock a square peg through a round hole and try to just piece things together. If we're going to do this, then we need to make sure that the development of the program side and the capacity is there to do it well, right? We've gotten pretty good at in-person services. We need to make sure that if we're going to provide multiple models, that both models adequately support people to achieve outcomes. And so what we see here is there's not necessarily a capacity from the provider side. And then let's go to the next slide, Mary Anne. So, we just need to kind of, again, step back and I think just take this temperature from the family perspective and from the self-advocate perspective. Would you do more of this if it was an option, right? So outside of the pandemic, just moving forward, if DDA said, yes, services can be provided virtually, would you do it? And what we see is a pretty resounding yes, right? I mean, people are saying, if we can figure it out, if I can be at home and I can be comfortable and still have ways to connect, I would do it. But I need the supports in place to be able to help me with that. And so it's important that as we think about that, and we see this now kind of increased interest, that we think about, well, what does that look like? And how do we make sure that services continue to achieve their intent, that we're keeping people healthy and safe, but really that a remote structure where we're not as hands-on or as actively engaged face-to-face still helps to make sure that people feel like they're connected. I think about the NCI data that talks about isolation, right? What we don't want is, because of the impact of isolation on, to say, well, we're just going to do everything remote and assume everybody's going to be okay, because they might not be, right? As we get more isolated, and we're all feeling this. I'd much rather be in a conference room with all of you talking about this data so that we're connected, we're seeing each other's faces, but we're all isolated to some extent. The more isolated we get, the less connected to community we are, and then the grander the impact on overall outcomes and quality of life we all have. And so if we're going to use this as a model that moves forward, then we need to be mindful of that. We don't have the answers right now. Nobody has the answers right now of how do we do that well, but if we can use this data to understand where people are, what the interest is, and then try to build a structure to support that, then we'll be in a better place. All right, let's go to my last slide here, Mary Anne. So we've talked a lot about data, and I know that it can be at times overwhelming, and what I should say is we showed a lot of data here. We didn't show all the data that we collected. There's a lot to go through, and it would cause you all to have to listen to me for hours on end, which nobody wants. But there's a lot of data. And so as we think about that, you know, what I always hope that somebody asks during a presentation is, so what, right? So we've looked at all these numbers. We've seen, you know, data is always looking backwards. We've seen what it's been. What does it mean as we move forward? And so I think there's some key questions that we have to think about through data like this. And, you know, as programs remain closed through COVID, you know, how can we use this data and this, what we've learned around remote supports to continue to grow that, right? Because we don't know when the pandemic is going to end. We don't know, you know, fully when vaccines are going to come into play. So how can we grow that remote support related to COVID to make sure that it's meeting the needs of the most number of people, and that we're doing it in a way that helps continue to support quality? You know, DDA, as I think everyone on this phone likely knows, it has been finalizing the Amendment 3 and really using that as an opportunity and this data to support it, to say, how do we build into our waiver programs the capacity to continue remote supports for those who find it supports their quality and that it helps them in their day-to-day lives. But as we do that, right, what we also need to be thinking about is what type of quality framework do we need to set up? So again, in traditional services, we've got a quality framework. You know, CMS, Medicaid has been using a quality framework for 30 years for in-person supports. We don't have it for virtual supports, and it's different, and it should be different. And so how do we use this as an opportunity as we move this forward, as we provide this as an ongoing potential opportunity for people to make sure that quality doesn't come afterwards, right? That quality remains at the forefront of this new service delivery model. And what does that look like? What does it mean? And how is it different through the use of technology? And then, you know, I think last is, and we talked about this a little bit ago, is what we're hearing from younger people coming into the service system, I think is what we've all known, but not really wanted to pay attention to, right? The service system that has been built over the last 30, 40, 50 years isn't necessarily the service system that they want. And so how do we use this information and this data to help understand that a little bit more, and what type of services they do want, or how they want to interact with services, so that we're able to support those who want to maintain traditional services, but we're modernizing the support structure to really meet the needs of younger participants who just interact with technology more than we have in the past, who expect that technology will play an active role in how they interact with services. And so, you know, I think that becomes an important piece here of, you know, how do we use this to increase choice for that group who says, what you've built, I don't want. So, you know, I think moving forward, you know, unfortunately, we, again, don't know when COVID ends officially. I wish I had that crystal ball, I just don't. But I think there are a few opportunities here, you know, to really continue to collect some of this data. Again, I think that there is a lot of opportunity coming out of this pandemic to really look at what service delivery in Maryland looks like. And so how do we continue to collect some of this data to inform that decision making, to make sure that all those voices are heard in that process? Yeah, I think then we also look at those support structures that are in place, and, you know, federal regulations and state regulations and, you know, other community-based resources that might help grow technology in a way within DD services that we haven't been thinking about. You know, I think there's a lot of opportunity through other sectors to be able to learn from here and say, you know, how have aging supports used remote-based services? How have child welfare systems used remote-based services? Where are there ways for us to learn here? Because we see that there is a demand for a web-based or a remote-based service structure. And then again, you know, and my background is in quality, so I always have to beat this, is how do we make sure that as we do this, we don't necessarily move so fast that we don't have the opportunity to think about the quality impact. You know, if we're going to build this as a standing service delivery model, then how do we ensure that we are supporting and considering and measuring its impact on quality, so that, you know, we can ensure that people, as they interact with a new service delivery system and as families become familiarized with the new service delivery system, that we're not doing it at the expense of quality, but we're really doing it to continue to support quality.
Absolutely.
So I'm going to stop there. And I just want to, Patricia, you've been an active partner in all of this. And so I want to give you the opportunity, you know, as you think about it from DDA's perspective of moving forward, anything you would add there around how this data is used or what DDA plans to do with it?
Thank you, Drew. You're so enthusiastic about data. It is incredible. All I want to say is I really do appreciate A&M as a consultant in helping us with this. I know that our Deputy Secretary wants to be able to make decisions based on data. What is our data telling us? And what an amazing opportunity that we had so many families respond to this and participants of our services. I mean, that was the biggest, I think, number that we had if you saw the slides. And of course, the providers responded, but we did that survey so early on that I'm sure now we probably get more folks. But I think what we're seeing is we're seeing that data is telling us the direction that we need to move forward. How do we engage? How do we add more remote supports? How do we make our services more flexible for the participants and the family? How do we make sure that not one service fits all, but how do we do an array of multiple things? And so I think that the way the DDA is moving forward is trying to use all this data, all this information, and then look to make sure to see that our services really support that, all the way from our waiver services. As you saw in our waiver amendment 3, we added more remote supports, more flexibilities. So, you know, I think it's if DDA can make decisions based on data, communication, what we're hearing from our stakeholders, and our stakeholders means providers, families, people in services. I think that we're a servant of the people. We are here to serve people. And so we have to lead by example. And so, you know, you can't go wrong with data. And then the staff advocates who gave us feedback on the survey, what worked, what didn't work. It's been just very, very helpful in the direction we move forward. So thanks for the opportunity to comment on that.
Thank you, Patricia. And Drew, I just want to thank you for your presentation. The your findings and this information is not only useful, but compelling, and certainly offers so much to consider and ponder as we move forward. And with that, what I'd like to do, I'm certain that our attendees, our audience, have some questions that they'd like to ask and want to open it up to folks. And I would just gently remind our attendees that if you'd like to submit a question, you can do so in the chat or question box. We would we really welcome questions pertaining to the topic today. If you have questions pertaining to specific services and supports, you have two options. One, contact your local regional office, or also your CCS. If they're related to Appendix K, here is you want to submit it to dda.toolkitinfo@maryland.gov. And with that, Ian has agreed to monitor the questions and ask them. Ian, do we have any?
We do. Good afternoon, everyone. My name is Ian Collins. I work very closely with Drew. And it does look like we have a few questions coming in. So I'll encourage folks to go to the GoToWebinar interface and go ahead and chat those questions in. I'd also encourage folks, for those who are not used to using GoToWebinar, if you go to the handout section, you can actually go and download the slides from today. So if you want to go back and look at anything that we covered today, you can go ahead and download a PDF version of what we're looking at for your own records. So it looks like we have both a mix of questions about the survey and questions about programs. So I'm going to start with questions about the survey. So the first few are going to come towards you, Drew. First, sort of just a logistical question. Would it be possible to get the full report from these studies? Is that information going to be shared?
Yeah, Patricia, I'm actually going to pass that to you. I think the intent is yes, but I will let you respond.
Yes, so the question is yes, and what we've done is A&M has done a really nice job at breaking it down by regions. So the regional directors actually have specific feedback specific to that region in that county. So the regional directors already have a copy of the survey, and we are going to have an opportunity to post this on our website and have it there available for people. But if you wanted to drill down a little more about your region, your county, and the area, the regional directors have that information as well. Great question.
Okay, great. Drew, this one I think will come to you. This question asks, do you have any qualitative data or drill down questions to show if the problem is with the type of activities on virtual, the lack of social interaction, the discomfort with virtual, virtual service delivery, or with something else? So really it's just, outside of sort of the answers to the questions, is there sort of qualitative information to back it up?
There is, and part of the challenge with analyzing qualitative information versus quantitative information is it's just really hard to put into a pretty chart, right? So there is a lot of that data, and I think what was one of the biggest benefits of the survey process was families were very candid in written responses of saying what is or is not working for them, and I think that's really where the rubber meets the road here, right? So we can look at this data and say, yes, generally this is the trend that we see, but it's really those stories and those written responses that add the color to this analysis. So I think in our report, that's really what we try to use, those responses as the context to this data. Numbers are great. The data doesn't lie. It is what it is, but there were a lot of really valuable qualitative responses in there that help shine a light on some of this data that the question itself just didn't get to. And so there is a lot of that. And again, I think it's something that is reflected in the report more so than we can do in a PowerPoint.
Okay, thanks, Drew. One more for you, Drew, but Patricia, you might have some insight into this one. And this is sort of around the intent for sort of the results of the survey. The question asks, are you planning on sharing this information with the commercial or virtual services industries to solicit their support and resources for this new emerging market sector? There's probably interest in the commercial sector to invest in identifying and building this new market for virtual services.
So I can tell you that DDA has been approached by multiple entities out there who's doing virtual supports. There's also several providers who have gotten together to talk to IT companies to look at this. They're also looking at how do you make systems more accommodating and flexible and accessible to our population more than ever before. I know that they approached several of us. So I think our goal has always been is when we talk to our industry about anything is how do we make sure that things are accessible to our population. And I know that the Department of Disability with DDA and assistive technology, we're always looking at making sure the vendors are, A, we have more vendors across the state, and B, to look at the different things like people who are hard of hearing, people who are blind, people who use other mechanisms. How do you make this user-friendly for people? And then what other services can people do outside of just taking virtual classes? How can you make it more interactive and more involved? And so I think if that's happening across the industry, I think it's making people and pushing people to that and consider all levels, because not everybody learns the same way. And you have people who are tech savvy and there's people who are not tech savvy, regardless of your age group or where you are. So, I always need assistance using my software. But I think we've learned a lot. Some people are very scared. Some people, iPads or tablets may not meet their needs just because because the person may use a peg or may use a different device or use the eyelashes to get the monitor to move or gaze. So, you know, I think people are looking at different ways. So that's a great question. I know that we've so far about 3 companies have contacted us, and I know that one provider is specifically working with a group of tech folks to really focus on our population. Drew, I don't know if you wanted to add anything to that.
No, I think that all sounds really good. I mean, I think that there is a lot of interest here, right? I mean, DD services for a long time didn't want to take the step into virtual supports. And so there are a lot of companies out there who have come up with some really unique, really innovative IT solutions. And so they're seeing some potential here. I think what, to Patricia's point, I think the biggest challenge and the most important piece of this is making sure that they're able to build things that really meet DD specific needs. And I think that's going to be the biggest barrier here is bringing them along on that side, because they're really good in behavioral health. They're really good in aging services, but we really need to make sure that they're really good in DD services so that if we're going to do this, again, we're doing it well and we're doing it right.
Right.
So we have a couple requests in the chat box for Drew's contact information and Patricia's contact information. Drew, Patricia, are you okay with me sharing that in the chat for folks in case they'd like to reach out to you?
Oh, absolutely. Yes, absolutely.
Okay, great. So I will drop that in, and just so folks know, it's their first name followed by a period, their last name at maryland.gov, in case you want to reach out there. But I've dropped both of those into the chat for all participants. One last question that mixes a little bit about the survey with a programs conversation. And so the question reads, for virtual day programs at residential facilities for older senior residents, are there discussions about the needs of this age group and how technology can support their day programs?
So let me address a little bit about what we're doing, only just because TTA right now has a lot of flexibilities under Appendix K and how people are using or implementing the day program. So we really want people to start thinking of the integrated start. We want people to really start thinking about person-centered. We want people to start thinking of what are their needs? What are their needs for technology, for community involvement, for all of those things that you hear Mary Anne talk about. We want you to use that and tie that in regardless of the person's age. So you're really looking at the person's interests, the person's abilities, the person's need for assistive technology, and then build supports around that. And Mary Anne, I know that you probably have a lot to say about this as you talk to families, but we really are looking at it doesn't matter on the environment of the service. It's looking at the person and their trajectory and how do you build supports around that, whether if it's a day program, community living, community development services, any meaningful day services. I mean, we have to look at the person in that integrated start and that trajectory. So Mary Anne, do you want to add to that?
I absolutely agree, and it's a beautiful segue. Our next webinar on the 9th is a training on the integrated STAR, and the integrated STAR is a powerful tool to assist an individual or a family or a program, what have you, in identifying, brainstorming, and identifying resources to address that issue. So the issue for a senior who would have normally attended program, but virtually within the residential services, you would use that to consider all of the options and identify those potential supports and services that would get at whatever their vision or whatever their goal might be. But you'll have to join us for on the 9th to learn more about that integrated STAR. And with that, I'd like to say I believe we got 2 minutes. It's 12:58. Ian, are there any other questions? A real quick question.
Maybe just one very last quick question for Patricia. Patricia, the question, and this is a programs question, is can a family member be a volunteer direct support professional or direct support person? And if so, what training would be required to get them up to speed?
Yes, so we can have families to be a hire person by an agency, and they could also be volunteer. We also want the families to follow the agency requirements. For DDA, we have some specific requirements. Your first day CPR, background checks, but we also have some flexibilities in Appendix K. But we do encourage families to be as involved as possible, whether they get paid or through volunteer. And so we do have that information on Appendix K. I think it was a letter. I think I wanted to say it was Appendix K letter 4 or 10. I have to look it up and put it in the chat. But we did have that information out of who can work and volunteer.
Thank you, Patricia. So I'd like to, our time is up, so I'd like to bring the webinar to a close. And so on behalf of the Maryland Community of Practice for Supporting Families and the Developmental Disability Administration, we hope you enjoyed this webinar, learned some things. We would also invite you to join us on December 9th for a training on the integrated STAR. And before we close, I just want to offer up a virtual round of applause for our guests, Drew, Ian, and Patricia. And of course, thanking Deputy Secretary Bernie Simons for making this possible. Otherwise, I take care and have a safe and wonderful holiday. Bye-bye.